Welcome to the Public Health Practice Gap, a podcast exploring why evidence-based public health programs so often struggle in real-world setting, and what actually helps bridge the gap between research, education, and practice. I am Bradley Fevrier, a public health educator and consultant with over 8 years of experience across higher education, workforce development, and applied public health practice. In this episode, I will begin with a paradox that many of us recognize intuitively, but don't always say out loud. Despite decades of research, despite evidence-based frameworks, despite best practices, guidance, and models, public health programs still fail, or fall short with surprising regularity. And when they do, the conversation often turns quickly to surface explanations. For example, poor execution, lack of buy-in, community resistance, or individual error. But those explanations rarely tell the full story. So today, I want to slow this down because this episode isn't about blaming practitioners, dismantling evidence, or questioning value of science. It's about understanding where things break down between good ideas and real-world outcomes, and why those breakdowns are often predictable, preventable, and structural. In public health, evidence-based has become a gold standard, and rightly so. Evidence-based approaches protect us from guesswork, from ideology, and well-intentioned but ineffective interventions. They give us confidence that what we're doing should work. But here's the uncomfortable reality. Evidence-based does not automatically mean implementation ready. Too often, we treat evidence as if it's universally transferable, as if a program proven effective in one setting can simply be lifted, replicated, and deployed elsewhere with the same results. In practice, evidence is always context-based. It reflects specific populations, specific political environments, specific funding structures, and also specific workforce conditions. When we ignore these realities, we unintentionally turn evidence into something brittle, something that looks strong on paper, but fractures under real-world pressure. This is where the practice gap begins. And one of the clearest, most painful examples of this dynamic is the Flint Water Crisis. The Flint Water Crisis is often discussed as a failure of governance, a failure of environmental regulation, and even a failure of ethics. All of this is really true. But it was also a profound failure of evidence translation and systems implementation. By the time residents began reporting concerns about water quality, there was already decades of evidence documenting: 1, the health risk of lead exposure; 2, the need for corrosion control; and also 3, the disproportionate impact on children and marginalized community. None of this is really new evidence. What failed wasn't knowledge. What failed was the system's ability or willingness to act on that knowledge in context. Decision makers relied on narrow compliance metrics rather than lived conditions. Data signals were discounted because they came from residents rather than official channels. Frontline concerns were treated as anecdotal rather than diagnostic. In other words, evidence existed, but the conditions required for evidence to matter were absent. And Flint is not an anomaly. It's a visible example of a pattern that shows up repeatedly across public health. Let me give you a few additional examples different domains, same structural problem. COVID-19 contact tracing programs. Contact tracing is one of the most evidence-supported public health tools we have. But during COVID-19, many jurisdictions launched tracing programs that were under-resourced, understaffed, poorly integrated into existing systems, or disconnected from community trust. That evidence says contact tracing works. The context said, not like this. The result wasn't failure of science. It was failure of implementation capacity. Another example is school-based mental health interventions. There is strong evidence supporting school-based mental health programs, but many districts implemented these programs without reducing teacher workload, providing adequate training, aligning schedules, and also addressing staffing shortages. So programs existed, but delivery was inconsistent, superficial, or unsustainable. Again, evidence without infrastructure. A further example is chronic disease prevention initiatives. Lifestyle and behavioral change interventions have robust evidence bases, yet programs often assume stable housing, food security, flexible work schedules, access to transportation. When those assumptions don't hold, outcomes suffer, and programs are blamed for low adherence, rather than misaligned reality. Across these examples, 3 failure points show up again and again. Design, context, misalignment is our first failure point. Programs are often designed under idealized conditions, but real-world systems include turnover, burnout, political pressure, competing mandates. When design ignores these realities, adaptation happens informally, and fidelity erodes silently. Failure point number 2, capacity blind spots. Capacity is frequently assumed rather than assessed. We assume staff have time, organizations have evaluation expertise, systems can absorb new demands. But capacity gaps don't announce themselves. They show up later as poor outcomes. And failure point number 3 involves evaluation as an afterthought. When evaluations is treated as compliance rather than learning, it tells us what happened, not why. And without the why, improvement becomes impossible. So, programs that perform better over time tend to share a few traits. Not perfection, but intentionality, early alignment conversations, honest capacity assessments, workforce first design, evaluation embedded from the start. They don't eliminate complexity, but they reduce predictable failure. When programs fail, the cost isn't abstract. It shows up as a staff burnout, community mistrust, wasted funding, institutional skepticism. Over time, repeated failure erodes confidence, not just in programs, but in public health itself. That's the real risk of the practice gap. As we wrap up, if you're working in public health education, workforce development, or program implementation, and you're grappling with gaps between evidence and reality, you are not alone. I offer a limited number of one-on-one public health strategy and advisory sessions each month for professionals and organizations who want a grounded, systems-level second perspective. These sessions are focused on clarifying goals, identifying structural gaps, and translating evidence into workable practice. And also, you can learn more at my website, which is nextgenpublichealthconsultancy.com. Thank you for listening to the Public Health Practice Guide. Until next time.